Hello, clinic techers. All right, I am going no cam today. You guys aren't going to be on camera while you watch this, so I thought it was only fair that I didn't have to get makeup on and put my work clothes on a Sunday afternoon to record this. So here we are. This is the 7th page of the lecture notes, week 9. This is pretty much where we left off last week, I should say, actually on week 9. So I'm going to start at the unwanted side effects, common occurrence, minor effects, and easily resolved situations. So these are things that are indeed going to happen for most of us fairly often, right? That's what a common occurrence is. But these things are not that bad, usually very easily fixed, easily dealt with. So let's get into it. First one here is pain on or after insertion. This is of a needle, of course. So remember that we can set the tone before we start needling, right? This is where we can learn how to prevent pain on or after insertion. So we want to make sure that our patient is relaxed before we start needling. If you see a furrowed brow, it might be a good time to start with some Tuina or some Moxa or something along those lines, right? Get them relaxed, get them happy. And then you also need to check in with yourself. The notes say your mental, emotional, and spiritual states greatly influence how a needle is introduced to your patient. So imagine somebody who is very stressed out needling you, right? Elevated heart rate. Person might have shortness of breath, right? They might be feeling a lot of things. Their chi is not flowing properly. They are not going to be able to give as gentle of a needle, and in my opinion, as effective of a treatment for that matter. So check in with yourself, check in with your client before you start needling. Keep in mind that we are inserting a sharp object into the patient's body. So the notes say here a small amount of discomfort is quite common with the insertion of needles. That is true. But this should not be every patient, every needle, every time. If that is the case, it's not them, it's you. Right? If this is happening every once in a while, if you notice that it's happening on certain points, oftentimes you might examine how you are needling that point. It might also just be that it's a stronger point, right? We know with points like large intestine 4, stomach 36, right? Those can get bigger reactions just on the insertion very often. So that is something that we can anticipate. But you should always be checking in with yourself as you are needling, asking yourself, why is this happening? Is this just the normal amount of small discomfort associated with a sharp object puncturing into the body? Or is this something that I am doing? So you want to evaluate your needle technique. That starts with your needles. So always continue to check in on your needles. I mentioned anytime you buy new needles, you should always check them out. But if you notice that there's a shift in your needling, whereas people were not feeling as much pain and now they are starting to feel more pain, then you are going to want to examine your needles. You might have gotten a bad batch. Then you're going to want to examine your technique itself. So what is your insertion like? Are you rooting your guide tube enough when you insert? Are you going swiftly and quickly enough as you are getting the needle to depth? Are you doing things like distracting patients who seem nervous? We'll learn how to do that in needle technique. Make sure that the needle size is appropriate. Make sure that you're not using too thick of a needle. Sometimes that can just be uncomfortable for people. Sometimes if you're using a needle that is too thin, it will be difficult to insert. That's particularly the case as you're a beginning level needler. So just assess what's going on. And then as far as pain after insertion, we can also talk about simple things like needling into a spot where alcohol used to clean skin has not dried before needling. It will be painful. It's an easy thing to address, right? Just wait. The needle contacting or being too close to something like a hair follicle, a sweat gland, wall of the blood vessel, a nerve, a tendon, a periosteum, all of these things can be painful, even if the needle isn't puncturing it, but is just too close to it. So very often, All you need to do, if somebody is feeling discomfort as the needle is in the muscle layer, all you have to do is pull it up about 1 millimeter. You'll still be within the channel. You'll still be able to get channel chi, but the sensation will completely change very often just by a 0.5 millimeter to 1 millimeter of insertion depth. If that doesn't resolve it, then you might need to remove the needle and perhaps reinsert it. If you contaminate the space, remember to re-clean the point. And sometimes there may be a point that you just can't needle today when you're needling a patient. Right? Sometimes an area is just particularly sensitive. You might choose a different point and move on. Excessive needle manipulation, particularly unidirectional rotational needle manipulation. What this essentially is, this unidirectional rotational manipulation, is screwing in the needle. You are continuously going in rotation and only going in one direction. You can create a tissue whirl at depth. You'll actually have little bits of the muscle fibers grab onto the needle. And as you are spinning that needle, it's getting more and more wrapped up onto that needle, which makes it painful, and it can actually make it very difficult to withdraw the needle as well. Next one here is excessive nervousness of the patient. We talked about this at the beginning, but it's really important that your patient be relaxed. Next one here, inability of the patient to remain calm during resting period with needles. Sometimes a client is okay when you leave them, but then you check at them at the 5-minute mark if you have a TDP lamp on them, or at the halfway mark if they are just resting quietly. If they need a check, they might be uncomfortable, they might be agitated, they might be nervous, they might be uncomfortable. So if that's the case, you might need to do something differently depending on that situation, right? You might offer them some music, some background music, or a white noise machine to help give them something else to focus on. You might even sit in the room and just do some breathing with them. I've had a couple of clients in my day where I have sat in a room doing charting or just doing breathing exercises with my client, just so they don't have to be by themselves. Next one in the notes here, predisposition to feeling pain from health issues involving more systemic pain patterns, things like fibromyalgia. So if somebody has a pain syndrome where they are feeling a lot of pain, they're likely to be more needle sensitive in general. You may treat them a little bit differently. Next one here, needling into guarded areas where a patient carries trauma or trauma memories. We'll talk a lot about this in needle tech and the different areas that people tend to hold their trauma and how to safely approach that. But sometimes things come out of nowhere. Oftentimes people don't even know that they're carrying these things in these areas. So they can come to a surprise just as much as you as it does to them. And that can cause discomfort, both physically and emotionally. And then, of course, this last one here, some drugs can make patients more sensitive to needling. You'll learn more about that in your pharmacology class. All right, so pretty easy to handle most of these, right? If your technique is poor, get better at your technique, right? Wait for alcohol to dry. And then just simple adjustments in needling can really go a long way to help people feel more comfortable with the needles. The next common occurrence that we're going to see is bruising or bleeding in small volumes. This is the most common adverse side effect according to the SAFA study that's on our class Moodle page. Bruising and bleeding are not inherently bad things. We may actually purposefully draw blood from a point, a drop or two. You will notice that certain points tend to bleed more. You will notice that certain points on people with certain constitutions will tend to bleed more. We know that heat causes the blood to move recklessly. So people with heat in their constitution or fighting off heat pathogens, they will bleed a little bit more and they'll bleed that nice bright red blood. And we may want to encourage that for therapeutic value. So not necessarily a bad thing. But if you notice a correlation between an active year behavior and the appearance of hematomas, then you need to start being more careful, or even just bleeding at points, because it might be your needle technique, not just heat trying to escape the body. So pay attention and tweak as needed. Bruises and hematomas commonly develop. I remember my first hematoma that I caused on a patient. I was very, very upset. I felt absolutely terrible, but I was able to luckily hold it in, be cool on the outside. And I was able to help the client with it. And I ended up sending her home with some liniment. and I felt absolutely terrible, and it like absolutely tortured me for 6 days. And then on the 7th day, I went back to my clinic shift the next week, and she was there, and she was fine, and she was fine with me, and she continued to see me until I graduated. So remember, things like this don't have to be a big deal. Even with the best technique, they are going to occur every once in a while. Every once in a blue moon, I still give a hematoma. I still give a bruise. Even with perfect technique, it is one of those things that just statistically is going to happen every once in a while. So pay attention to your needle technique, of course, but know that sometimes these things are just going to happen. So if we have somebody who gets a little bit of a bruise or a hematoma, what we are going to do is offer them a liniment. When we're in class, I actually keep 5 Photos brand liniment around when we're doing our needling. And all you have to do is shake up the bottle, put a little bit of it on a cotton ball, and use some medical tape to tape it to the local area. We're going to put it right on top of the acupuncture point, and it will help to reduce the swelling. It'll help to move the blood to decrease bruising. As far as bleeding in small volumes, we are just going to grab a glove, grab a cotton ball, and sop up the blood. Most of the time, when you get bleeding from an acupuncture point, it will be a small amount of blood, 1 to 3, maybe 3 drops of blood. That is pretty uncommon, though. And as long as you haven't saturated your cotton ball with blood, you can just toss that cotton ball right into your trash. If a cotton ball becomes so saturated with blood that you can actually squeeze it and have blood come out, so completely saturated, that is when you would need to get a biohazard container to put that in. So for most of us, this is not going to be something that we come across really unless you are doing specific bleeding techniques like wet cupping. You are not going to encounter this much blood. All right, and looking at this next section here, we have unwanted side effects. Uncommon occurrences, potentially more severe, but not urgent or emergency situations. So these are not call 911. These are just take a breath and handle the situation sort of things. So stuck needles. These definitely happen. Stuck needles happen. I have definitely gotten needles stuck. I have seen people with stuck needles. There are certain body areas that tend to have more like a higher likelihood of stuck needles. We'll learn a lot about that in needle tech. But this is definitely something that is going to happen. So do not panic. That's like the first thing that you want to do if we look down here at our actions. But all of these situations, just don't panic. As long as you play it cool on the outside, you can freak out in your head, but just play it cool on the outside. Because you're really going to set the tone for this. Oftentimes, when you have a stuck needle, the patient doesn't even have to know that anything has happened because you're just going to fix the problem before it becomes a major issue. So as far as signs and symptoms of stuck needle, how do you know you have a stuck needle? The needle will feel caught in the tissue. You'll try to pull it out, and the body will it will feel like the body does not want to let it go. It will feel like it is being grasped by the chi. You'll know it when it happens. Potential causes, very common one is needle bent at depth. So if we have a needle that is seated right in between the radius and the ulna, for going in between those two bones into the communis tendons, like say on the Sanjiao channel, you might have a needle that is actually going in between the bones. If you were to change the orientation of the arm so that you go from a neutral orientation to having the radius crossed over the ulna, you can absolutely bend that needle. So if that happens, you are going to have the person return to their neutral position and then try to get the needle out then and only then. It might be because of a spasmed muscle. This is very, very common. I see this a lot in the large intestine channel, actually. LI4, LI10, they tend to spasm, not very infrequently. You'll get a big muscle twitch when you insert those points. So it's enough sometimes to kind of grasp the tip of the needle, so it's difficult for it to remove. If you are doing that unidirectional rotation, you may end up entangled in fibrous tissue. You may end up doing too aggressive of stimulation to a needle and getting it stuck. So In general, when you get a stuck needle, first thing, look at the notes here. Action, calmly reassure yourself and, if necessary, the patient. I can promise you this. Generally, patients will panic if you do, and generally they will not if you do not. So again, it's really up to you to set the tone for all of these unwanted situations. So take a deep breath, wipe the sweat from your brow if such a thing exists. Remember that the person on the table can hear you. So choose your words with that in mind, if any. Again, this is a situation in which you may not need to tell the patient anything has happened because you'll be able to fix it quickly enough. But do not utter the words, oh dear, or oh darn, or oh my God, or oh, any 4-letter word, right? If they hear you uttering expletives, they're going to know something is wrong. They go into panic mode. So be cool. Next bullet point, ensure that the position you need them is in the position they are in now. So again, if we're talking about the radius and the ulna, we want to get those back into neutral orientation. Down on the gallbladder channel, on the leg, if we have any change of the tibia and the fibula, that might cause some issues there. So make sure you put them back in the position in which you needled them. If the needle is still stuck after that, you can massage or tap around the needle. You can use heat lamp or moxa to bring blood and chi to the area, get things moving. You can puncture into the same muscle or into the same channel further down the line to help release the needle. And if none of these things work, you can use your hemostats to maintain a grip on the needle to give yourself a little bit more leverage. Since your hands are probably going to sweat the first few times this happens, I suggest you get some hemostats onto the needle relatively quickly. So try and go through all of these possibilities as quickly as you can because you don't want it to last very long. You don't want to panic too much. Make sure when you pull the stuck needle out that it is the same length when you put it in. So make sure that the needle did not break off at someplace mid-shaft. Make sure that the tip of the needle comes out with the rest of the needle. Now, how likely is it for you to get a stuck needle? 100% it is going to happen. How likely is it that you get a stuck needle that you cannot fix and you have to go down to just using the hemostats? Not very likely. I know plenty of practitioners who have been out in the world for decades who have never had to break out their hemostats. They've had plenty of stuck needles, but they have not ever needed to use their hemostats. So most of the time, in my experience, all of the time, one of these things will work. Usually just a little massage. Oftentimes, the other thing that I will do is let the needle sit. So if I can't get one needle out and I've tried everything, I'm going to put a heat lamp on it and I'm going to walk away and pull a couple of other needles. And then I'm going to come back to it. Very often, that's all you need, is to just give the body a little bit of time to relax. All right, next up is a broken needle. So this is one we hope we never have happen. Nowadays, needle breakage is not a common occurrence because we have these single-use needles. They are not being autoclaved over and over again, so they're not being broken down over time. So unless they're factory defects, this should not be a problem if you properly take care of your needles before you use them. So how do you know if you have a broken needle? You will pull to withdraw the needle and only some of it will come out. Some of it will remain embedded in the patient's body. Typically, when this happens, we are going to see it happen where the handle meets the shaft. That's called the root of the needle. That's where they're weakest. This is where this is most likely to happen. This is also the case because it is weakest because this is actually two pieces of metal fused together. So the shaft and the handle of the needle are originally two separate things that are bound together. So of course, that's where it's most likely to break. I have never seen a needle broken off inside of a patient's body. I have never actually seen a broken needle. I have a couple of colleagues. My mentor, she saw a pipe handle separate from the needle shaft, leaving a wire sticking out of the body, but never seen a needle embedded in anybody. I don't know anybody who has ever seen a needle embedded in anybody from a broken needle. So is this a common occurrence? No, absolutely not. But it is within the bounds of possibility. So as far as potential causes, it's going to be poor needle quality or poor needling. So either inserting the needle to the root. You never ever want to bury a needle. Leave a few tenths of a sun of the shaft showing above the skin surface, just so that we never have a needle buried inside of a patient. Excessive force on the needle at depth, so just too much manipulation. Needle struck by external force. So if a patient faints and falls off the table, perhaps it might break the needle. Poor quality needles or needles with imperfections in the metal, or a bent needle gone awry by forcibly removing it. So what do? First and foremost, stay calm. Keep the patient in the same position that they are in. Keep them from moving. There are a couple of different scenarios here. If you can see the shaft of the needle, you can get your hemostats, pull it out. If the needle shaft is level with the surface of the skin, you can gently press down on the skin to either side of the needle to help kind of push the needle back up and expose it. Grab it with the hemostats. But I cannot stress this enough. Be careful to not push the needle further. And then lastly, if it is embedded, if you go to withdraw a needle and you look at the needle as it comes out and you notice that the whole thing isn't there, and you look at the patient's flesh and you cannot see that needle, if it is truly embedded in them, you need to immobilize the area and get medical help. You should never cut a patient open in an attempt to remove it yourself. That is not within our scope of practice. It is fully illegal for you to do. It would also be very painful and unpleasant for your patient. So leave that for somebody who has that in their scope of practice. I would take this person, depending on where this happened. If it happened on the arms, I would probably just take the person to urgent care. If it really happened anywhere other than the arms, if it happened anywhere on the torso, if it happened on the head, or even if it happened on the legs, I wouldn't want them walking. So at that point, I would call an ambulance and have them picked up. So again, not a common occurrence. All right, problems when needles are combined with other modalities. Essentially, you're going to learn more about this in advanced needle techniques, so we are not going to talk about this. I'm not going to test you on it, but I did want to include this just because you all are exposed to these sorts of things in the clinic. So not going to test you on it. You want to read this on your own just so that you know. It is very valuable information, but you will get education on this in advanced needle tech when you actually learn how to combine these modalities. So I leave this in here because I want you to read it, but we're not going to spend any time actually talking about it. All right, next one, loss of consciousness, alterations in states of consciousness. Now, ideally, this is the most serious adverse reaction with which you have to deal. As far as alterations in state of consciousness, these don't necessarily have to be a big deal. Somebody might fall asleep, or somebody might have a dissociative state for a moment, right? They might have an out-of-body experience. That is something that happens to some people. As long as we can get the person to come back to us, right? If you can wake the person up and have them give consent to things, right? We want to make sure that we can still get consent. So other than those things, when we talk about altered states of consciousness, we could also be talking about a seizure. We could also be talking about a panic attack. We could be talking about a personality switch and person with multiple personalities. So as far as those bigger emergency situations, those are more major medical red flags. We'll talk about major medical red flags in a little bit, and you'll also get a lot more information about that in your pathophys classes. So this isn't where we're going to learn about that. As far as the notes are concerned, we're going to focus on ordinary vanilla loss of consciousness. So this is if somebody just passes out in your treatment room. We want to be aware of the potential for loss of consciousness. Some people are just more predisposed, more likely to lose consciousness in our treatment rooms or in our waiting rooms. Those of us who are new or nervous, some people are just needle nervous, needle sensitive. I find that those people are more likely to lose consciousness. New patients, again, might be more nervous because they don't know you. If you have someone not lying down for a treatment, so seated treatments, more likely for the person to lose consciousness. I did actually one time give my best friend a treatment at my house, and she was seated in a lazy boy chair, and she ended up losing consciousness while we did the treatment. She came right back too, but ever since then I've been very hesitant to treat people seated. Someone who has not recently eaten or has not recently slept well. This can make people more needle sensitive, and this can make people a lot more likely to lose consciousness. If you are doing aggressive needle manipulations, people's energy is moving stronger and faster, they are more likely to pass out. And just in general, when you're needling neck, head, and upper body points, remember a well-balanced treatment can help you minimize chances for this. When we get to needle tech and we're doing the yin of arm, the yang of arm, I'm going to give you grounding points to do. They won't be mandatory, but for the more needle sensitive folk, you're going to want to utilize those points to keep them feeling good. Notes say here you may see signs of dizziness as or after you gua sha on the neck and upper back. So if a patient says they feel dizzy or they feel funny, oftentimes people know when they're going to pass out. The last time I passed out, the last thing that I said was, I think I'm going to pass out. So oftentimes people will know, especially if they have a history of losing consciousness. Dizziness is oftentimes a precursor to losing consciousness. So if they say something like they feel dizzy, they feel like they're going to pass out, we want to keep an eye on them. If they start to get worse, we are going to move into action phase here. So some general signs and symptoms, things that we're looking for: dizziness and vertigo. They might report palpitations or an oppressive feeling in the chest, like a heaviness. They may see visual distortions. Things might get blurry. They might see a collapsing visual field. The last time I lost consciousness, it looked like a curtain falling, standing on a stage. It was just everything just went black from the top down. Someone might feel like they're having a panic attack. They may actually have a panic attack. You will notice a weak pulse. They may lose consciousness. You may get hypotension, nausea. Very often people will lose the color in their face. Regardless of what color that is, they will go to kind of an ashen gray hue to their face. We did have a patient, the first patient that I ever saw as an observer, my first day of clinic, my first semester being in clinic, the very first shift, the very first patient, about halfway through the needling, she mentioned, yeah, I kind of feel funny. And the intern and I both looked over at her at the same time, and we could see the color just drain from her face. She went from very rosy cheeked to the color of sidewalk. I will never forget it. And immediately my intern sprung into action, did the right thing, and she was fine. She didn't actually lose consciousness, but she said that she felt like she was a few seconds away from passing out because she had a history of syncope. So signs of shock. Again, perhaps I feel like I'm going to faint. In some people in a seated or standing position, you can literally watch the blood drain from their face. So that is absolutely what I saw with that patient. So as far as potential causes here, no surprises. If a person is nervous or tired or fatigued, they haven't eaten, if they're just generally weak, they're more likely to lose consciousness. Too aggressive of needle manipulation and imbalanced needling in the upper body. So again, we want to make sure that we have some grounding points if we're going to be doing a lot of upper body needling. So if this happens, even if somebody doesn't lose consciousness, but you suspect that they will, first thing, it's not on the notes here, but we know already, stay calm, but also move quick. Remove needles immediately and make sure they are steady, bolstered, and cannot fall on needles. And make sure that they cannot fall in general. Sometimes you might have somebody bolstered in a way that if they lost consciousness, they might roll off the table. Make sure that you prevent that from happening. As quickly as you can, get them into a supine position with their feet slightly elevated. You want their feet over their head, their feet over their heart. You may want to help them to the ground if they're seated. The ground is the safest place because they can't fall if they're already on the floor. Calmly reassure yourself and your patient. Again, remember, patients will panic if you do. Be alert for abnormal signs such as patient not breathing. Make sure to keep them comfy, keep them warm. If they are conscious, if they don't lose consciousness, you can offer them something to drink, but do not ever offer or give food or drink to an unconscious person. If they lose consciousness, you can try to resuscitate them by pressing a fingernail to do26. That's the poodle point, right underneath the, on the philtrum, underneath the septum of the nose. Needle do26 and PC6. You can press moxa or needle at stomach 36 and LI4. There are resuscitation acts like calling wake up. You can use your knuckles to rub against the person's sternum, or light slaps to the face or shoulder shakes, something to help them shake out of it. And if they lose consciousness, call 911. It is absolutely necessary. If they lose consciousness and they come back to consciousness, you can talk to them, but I would strongly suggest getting them to a medical facility to get checked out if they lose consciousness. So this is an important question always arises. How long do you let someone stay unconscious before you summon help? Mostly people will recover on their own within a few seconds, almost all within a minute or two, particularly if you stimulate do26. I have heard that 2 minutes is a good general rule of thumb. If you are able, when a person loses consciousness, one of the first things that you should try to do after making sure they are safe, they're in a safe space, they're in a safe environment, they're not going to fall and hit anything, nothing around them is going to fall on them. You want to check the time. The amount of time that a person is unconscious is very important in their recovery if they remain unconscious. That will also tell you when you have your 2-minute window to call 911. So look at your watch. If 2 minutes go by, you're trying to resuscitate them and they're not getting up, then you need to call 911. If they do, again, I would strongly recommend to the person that they go to an urgent care facility and just get checked out and make sure that everything in their heart and their brain is okay. Further consideration here, I want to go through these. Passing out will likely result in termination of the original focus of that day's treatment. So I would strongly suggest if this happens, do not try to continue the treatment. I strongly suggest that you do not let someone out of your office until you are sure they are fully recovered. Make sure you give the person space to recover more after fainting. You might even offer, I would definitely offer, I've never had anybody lose consciousness in my office, knock on wood. But if I did, I would offer to call their emergency contact, or have them call someone on their phone, or even send them home in a Lyft or an Uber or something like that to make sure that they get to their safe space, their home, or with a friend or something like that, if they don't want to go into urgent care. Your patient may be very embarrassed at having fainted. Again, you need to set the tone. So if somebody does lose consciousness and then they come back, be as comforting and as non-judgmental to them as possible. Make sure that you make them understand that what happened was not their fault, and they have done nothing wrong. Your patient may have a seizure disorder. Be aware of how to handle seizures on the off chance that they have one while they're in your office. This is another reason why we always want to look at our health history forms. Even if we're treating somebody for shoulder pain or ankle stiffness, right? We think, oh, we don't need to do the full intake. I don't need their health. Yes, you do. You need to know things like this. If somebody has a seizure disorder, they will probably know what they want you to do if they have a seizure. So ask them what the protocol is. Discuss it with them. Ask them if they have post-seizure auras, things that you can both pay attention to see to prevent them from getting a seizure in an inopportune space. So if you know that they're coming on to a seizure, you're going to take the needles out, just like any sort of alteration in consciousness. And just I feel like this is common knowledge now, but if a patient does have a seizure in the room, not only are you, or in your waiting room or your treatment room, not only are you going to remove the needles, but you are going to try to get them to the floor, get them away from, again, anything that can fall on them, get them to the floor so they can't fall, and do not stick anything in their mouth. Used to be the wooden spoon in the mouth, so they wouldn't. That's not a safe thing. It's actually very dangerous. So just make sure that they're on in a safe place, and make sure they're not going to bonk their head on anything, and wait for it to be over. All right, next one is lost needles, aka uncontained needles. So lost needles fall into two categories: ones that are forgotten in the patient, or ones that are missing when we go to remove them from the patient. So needles can fall out during treatment. They can fall out after they get up and move around. So make sure that you are paying attention. Factors that contribute to lost needles include things like inaccurate or untimely notation in soap charts. If you didn't chart how many needles went in, you are not going to necessarily remember how many you need to pull out. So something that interns will sometimes do to ameliorate this is before they leave the treatment room, they will just take their pen and write at the patient's foot on the table paper the number of needles they put in. You might also write it on your hand. You might also chart it immediately, but having it written down can be very helpful. Next up, forgetting to needle an acupoint that you thought you needled leads to a perceived lost needle when one does not actually exist. Hurrying during withdrawal. So you might forget a needle, you might drop a needle onto the floor. Same thing goes for distractions during withdrawal process. If you're not being mindful, you might have a problem with lost needles. Trying to remove too many needles at one time, particularly multiple sizes at the same time, you might unknowingly drop a needle. It's very easy to do that. And dropping a needle in a carpeted room, it can be very difficult to find them unless you actually see it drop out of your hand and you can spot it quickly. Next one here, not immediately containing sharps after withdrawal or if the needling process is interrupted. So once a needle comes out of the package, it should immediately go into the patient. And once that needle comes out of the patient, it should immediately go into a sharps container. That will eliminate this problem. Next one here, removing needles in inadequate lighting conditions. Some points might get hidden. You might not see them, so you might forget that they exist. Communication difficulties between the people who inserted and the people who removed the needles. So if you have somebody, if it's not the same person putting them in and taking them out, if you don't communicate properly, they might not know that they have missed a needle. Last bullet point on this page here, sometimes we lose a needle because it falls out during treatment. This oftentimes happens with auricular and e-stim, especially if the weight of the cord is pulling out on the needle. This is actually very common with poor e-stim technique. Some people also just pop needles out, like a turkey with a turkey timer. That's how I am with my acupuncture needles fairly often, actually. I don't generally push them all the way out. They will just be more shallow, but my acupuncturists have come back and had needles laying on the table next to me that used to be in my body, and I didn't move or anything. Last one here, errors during the disposal process. Touching the wall of the sharps container as you put a sharp in can actually cock the needle like a spring, only to have it catapult out of the sharps container. The last needle stick incident that we had before COVID, this was actually the case. The intern wasn't watching as she put her needle into the sharps container, and it actually got caught and kind of boomeranged back out, and it poked her right in the finger. So it was a used needle. So prevention of this situation is the best cure for it. So just think about all of these possible causes and make sure that you do not fall prey to them. There are a few ways to coach patients to treat a needle if they happen to find a needle in their body or in their clothing when they're finished with their treatment after you're done removing the needles. If they're nearby to your office when they discover it, have them return to if it's still in them, remove the needle. If not, just bring it back. If they are too far gone to turn back, they can contain the needle in an empty pill bottle. You can also put it into a piece of paper, kind of origami it, fold it up into a piece of paper, and then wrap that piece of paper in duct tape. Essentially, you don't want this needle sticking out and sticking somebody, right? They can bring it back to you for the next visit. They can, just encase the needle in a piece of stiff tape like duct tape, and then again, bring it back for your disposal. And then you would take that needle and put it into your sharps container. All right, next one here is aggravation of symptoms. So things can get worse before they get better. Sometimes that is just how the treatment goes. I always tell my patients that is a possibility. Sometimes that's just their healing journey. You open up things that were so closed off because they were so unwell that they feel like they're getting worse, but they are actually on a healing trajectory. Aggravations can sometimes leave a patient feeling unhappy. So again, you want to make sure that you talk to them about this before treatment. But sometimes it can be us, right? More often than not, this is not going to be the case. Most of the time, patients will just feel better and feel better. It should be less frequent that your patients feel worse before they feel better. So if you notice a trend where more than half of your patients are feeling worse before they feel better, you might check your technique. You might check your technique for your intake, for your diagnosis, for coming up with your treatment plan and your points, what techniques you're using, how you're using them, right? You might examine you and your work. But sometimes this is just an inevitability. All right, moving down the line here, we have unwanted side effects. These are rare occurrences, potentially serious adverse effects. These are urgent situations. These may be times at which you take someone to urgent care, or it may even be a time that you call 911, depending on the situation. So if we have a puncture of a large blood vessel, we are going to see pain. There's going to be bleeding, discoloration. When you're in the neighborhood of an artery, you'll commonly see the needle bob from the pressure wave hitting the needle shaft. That doesn't mean that you are about to hit an artery. It could just mean that you are nestled right next to it. This is very common at lung 9, Ren 22, stomach 9. If it's not painful, it's not a problem. But if you do actually puncture, this might be caused by ignoring signs that you are encroaching on a blood vessel. There will be a change in density. You'll learn about this in needle tech, how to feel what tissue, what appropriate tissue feels like. If a person moves after needling, they might drive the tip of the needle into a blood vessel. And if the patient has an inability to feel pain in an area while being needled, this is not very likely to happen because you will prevent it from happening. So, action prior to needling: avoid blood vessels. Be aware of bleeding disorders or people being on blood thinning medications that can worsen blood loss. Put on gloves on both hands, grab as much cotton ball or sterile gauze as you need, remove the needle, stop the bleeding with direct pressure. If the cotton ball or gauze you're using gets soaked, add another one to it. Don't remove the compress. So don't pull a soaked one off to put a fresh one on. Just keep stuffing, just essentially keep plugging the hole. Do not remove pressure. Hold firm pressure on the point for as long as it takes. It can be up to 5 minutes. Arteries typically take up to 5 minutes, but veins 30 seconds to a minute. Blood thinners and bleeding disorders lengthen that time. So if you have severe prolonged bleeding, biomedical first aid recommends compression, ice, and elevation of the area to help stop bleeding. Once you've stopped the bleeding and stabilized the situation, clean up the mess. If you have cotton balls or sterile gauze that are saturated with blood, right, if you can squeeze them and blood comes out, that means they need to go into their own biohazard container, not a sharps container, into a biohazard bag. We have these on school premises. If you need them, tell your supervisor, tell your teacher, and we can get them for you. You may need to discard some table linens if they become soiled with too much blood, right? Would just throw those away and use new ones. But this is not a situation in which you are going to need to take the person to urgent care necessarily. If the bleeding stops, just make sure that the bleeding is stopped, and then you can put a Band-Aid on them and send them home. Same thing with puncture of tendons, ligaments, nerves, or even minor organs, depending on what they are. The word minor here, we are talking non-emergency, non-life-threatening. There's pain associated with these things, but these are not dangerous situations. So signs and symptoms here: intense pain that may linger for a long period after needling, could be up to 2 to 3 weeks post-incident. Difficulty using whatever structure after needling. So there may be some issues with range of motion or even immobilization of certain areas. There may be bleeding or bruising. Depending on the injured organ, you might see other symptoms. As far as potential cause, This is generally going to be from poor location, poor control of angle, depth, direction when needling. It can also be caused by patient movement after needling. So repositioning from body jerks during a cough or a sneeze, or if somebody loses consciousness or has a seizure, right, the needle may end up moving to into a puncturing a tendon, ligament, nerve, or minor organ. So if this happens after you recognize that you've hit something, remove the needle and control any bleeding, right? So if you have bleeding, stop the bleeding. The symptoms will vary depending on what happened. So you're just kind of read the situation. If there's an accidental puncture of a minor organ like the eye or the bladder, you should definitely send them to an urgent care. Accidental puncture of tendons and ligaments don't require any sort of medical intervention, but you're probably going to want to send them home with 5 photos brand liniment or something like that, some topical liniment with strong blood movers. In my experience, after using 5 photos liniment, if you start to move the affected area, the tendon or ligament within the patient's pain tolerance, it can help to speed recovery and normal functioning. All right, so I talked about how to use the 5 photos liniment here. But really what the notes talk about here, as with most needle incidents, the best way to treat it is to avoid it. And it's really knowing your location, your angle, depth, direction, and then making sure you're paying attention to your patient. That's really what it comes down to. A couple ones that I want to mention specifically here. Be able to discern true Da Qi from false Qi. So sometimes we might have a person say, ooh, this hurts. You need to be able to determine whether that is just a dull ache, heavy pressure sensation from true Da Qi, or if it is the pain associated with the striking of a structure. And then last one here, note that you may see delayed symptoms, delayed development of symptoms. So the person might be fine when you put the needle in, but you might come back to check on them, or you might come back to pull the needles, and then they might report some discomfort. All right, next one. Of course, we hope that no one ever gets an infection in your office. As long as we adhere to our clean techniques, we are limiting the possibility of infection. Keep in mind, there are things out of our control. They can and do still occur, but we can utilize our safety guidelines and precautions to prevent infections. So the notes here talk about following CNT, following standard precautions, right? Following safety guidelines for hand sanitation and preparation and maintaining of a clean field. All of the things that we are learning here in this class, as long as you do this, it is not very likely that you are going to transmit illness in your office. All right, another one. This is very particular to us as acupuncturists, needle stick or other percutaneous incident. So we hope that this doesn't happen. It is a possibility. Most acupuncturists go their entire careers without ever experiencing this, but it is a possibility. We have had needle sticks not only from disposing of needles, but also from cleaning tables in the Pacific College Clinic. So make sure that you are careful when you are cleaning, if you ever clean, when you clean, in between, in the crease in the massage tables. Make sure that you push them up and do a visual examination before you stick your hand in the crack to make sure there aren't any needles in there. We've had plenty of near misses here. You can read about these. You can also read about these examples of percutaneous incident. I strongly encourage you to think about these various unwanted side effects and occurrences as real world situations. Something that I am going to do on our final exam for this class, on our midterm and our final exam for needle tech. You will get these questions in advanced needle tech. You will get these questions on your CNT national written section, is what I like to call story problems, where they will, the question will walk you through a real life scenario and then ask various questions about it. They might ask how many things the person did wrong. They might ask you whether or not there is a risk of transmitting infection in a situation. They might ask you how you would handle a situation. In other words, how you would handle an emergency situation. So don't just memorize this information. Make sure that you really think about this in a real life sort of way. because you are definitely going to have to answer questions about that through that lens. All right, last major section here, unwanted side effects, very rare, very serious adverse effects, emergency situations. Remember, these are emergency situations, so failure to act in an appropriate and timely manner may result in severe injury or death. This is the big scary stuff that most of us, knock on wood, knock on wood, knock on wood, most of us will never, ever come into contact with. Most of us will never experience these things. So, again, we need to know what the zebras look like. But remember, most of the time we hear hoofbeats, it is going to be just a horse. All right, first one. This is a very, 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 very major concern to us as acupuncturists. Lung puncture, also known as, commonly referred to as pneumothorax. So pneumothorax is actually defined as the abnormal presence of air in the space between the lung and the chest wall, preventing lung expansion. But we refer to pneumothorax as lung puncture. It's kind of a shorthand, right? Because when you puncture the lung, this is what happens. It allows for air in that space. It can occur from an object penetrating the lung, from blunt force trauma, or spontaneously with no impact or penetrating object. So the notes here talk about the different kinds of pneumothorax, essentially the different causes. We are responsible for iatrogenic pneumothoraces. This is one's caused by medical procedures. Those from acupuncture treatments would fall into this category. There are certain conditions that put people at higher risk for pneumothorax. So we need to know these things, right? And we need to look for them in our patients. This, again, is why health history is so important. Even if I'm treating somebody for shoulder pain, I am going to look at their health history. If they have COPD or emphysema or something like that, they're more likely to get a pneumothorax. I am going to needle them with greater caution, even if it's just shoulder pain, because that area is right around the lungs. We need to understand that certain body locations are endangerment sites. So anywhere along the torso where we are at the intercostal spaces, anterior, lateral, and posterior. In the supraclavicular fossa, so even above the lungs, and then points around the shoulders. So historically, this is a list of points that have been involved in pneumothorax. It is not a short list. We have a lot of endangerment sites for this, right? I have third-hand knowledge of precedents of pneumothorax within the Chicago acupuncture community. It was at GB21. We just at this point last week in Needle Tech, and I had mentioned to my students that a supervisor of mine when I was a student would not allow students to needle GB21 because she was afraid of it. There's no need to be afraid of GB21 or any of these points for that matter. As long as you are accurate with your location and your angle, depth, and direction, unless someone has pathology, you are going to be fine. So how do we know that we've caused a pneumothorax? Typically, you're going to have pain in the chest and coughing. Sometimes it's only with an inhalation, only with deep breath. Sometimes only with exertion. There may be difficulty breathing or rapid breathing, cyanosis, sweating, pallor, or even loss of consciousness. This can happen immediately or as the condition worsens hours later. There was an instance, the notes talk about somebody only showing minor signs until 18 hours after the needling occurred. So some mild coughing is all this person exhibited. I'm not going to suspect, especially in the winter months, right? I'm not going to suspect somebody having a pneumothorax if they just have a little bit of a cough when they're leaving my treatment room. But remember, death can result from a pneumothorax if it is not handled properly. If it is fine. People can absolutely walk away, no harm, no foul after a pneumothorax if it is treated. So if you suspect pneumothorax, withdraw the needle immediately. This is counterintuitive to everything that you have ever learned about organs being punctured, right? We've all seen like a movie or a TV show where someone gets some large object penetrating into their thorax and they go to take it out and someone says, no, don't take it out, don't take it out. This is not one of those situations because they are not dealing with acupuncture needles. When you have a large object wedged into an organ, the lungs in particular, since we're talking about the lungs, you don't want to remove it because it's going to make it worse. But when you have a teeny little acupuncture needle, if the tip of that needle is seated in the lungs or at the lungs, the delicate lung tissue can be damaged by tearing from breathing or coughing while the needle is still in place. Our needles are so small that if you pull them out, there's not going to be a big hole in the person's flesh. The surrounding tissue is just going to come back together because our needles are so small. What we are concerned with the idea of not taking something out when it has entered into the body is because it is going to leave a hole, and that hole is going to cause more damage. This is not the case. Leaving the needle in will cause more damage. So withdraw the needle immediately, keep the person still and lying down, and as fast as you can, call 911 and get them to the hospital. Next up, puncture of heart, liver, spleen, or kidney. It is exceptionally rare, but still within the bounds of possibility. I don't know of any occurrences within Chicago or the United States of these organs being punctured. So it is not very likely that this will happen. What we are looking for as far as red flags, pain at site of needling, and this is going to be intense pain. There's going to be internal bleeding, so we're going to see that as hardness of the abdomen, rebound pain, color change locally, some lumbar pain possibly, tenderness and pain on percussion in the kidney region, or blood in the urine if there's actually puncture of the kidneys. Accidental puncture of the heart can result in death, and that's the most immediately dangerous in this category. We will discuss endangerment sites as we learn to needle these points. So as we go through these points in Needle Tech, I will talk to you more about how to safely needle them. So that is how we are going to prevent this. Again, location, angle, depth, direction. If you suspect a major organ puncture, remove the needle, stop any external bleeding, and again, immediately as fast as you can, call 911 and get this person to the hospital. All right, last one here is brain and spinal cord puncture. Again, exceptionally rare, but still within the realm of possibility. Take steps to minimize the risk. Know your location, know your angle, depth, and insertion direction and manipulation. With this, in particular, the brain and the spinal cord, be particularly mindful when needling on the due channel or at the base of the skull. I'll talk to you a lot more about this in Needle Tech. Possible signs and symptoms: if you suspect convulsions, paralysis, coma, this is immediately an emergency situation, and you will know that it is immediately an emergency situation. Call 911 immediately. Keep the person as still as you can. So, handling emergency situations, just some basic things to keep in mind. Common sense stuff. Stay calm. Maintain professional behavior. Like I said, you could panic in your head, but just be cool on the outside. Think about how you would like to respond to emergency situations that occur in your office. So not only do I want you to think about these things as real life scenarios, because you're going to get tested on it that way, but also if any of these things actually do happen to you in real life, it is much better if you've already run through that scenario in your head once or twice and asked yourself how you're going to handle it and kind of gone through those motions in your mind. It won't be as foreign or scary or difficult if you've partially experienced it already. At least think about the following things here. Let's look at these bullet points. Do you know emergency phone numbers to summon medical professional help? Do you have access to a phone when you're in your treatment room, when you're in your waiting room, when you're in the bathroom while your patient is on the table? Do you have emergency phone numbers to contact people according to your patient's wishes, right? Do you have emergency contact information? What is the right response to non-needling accidents within the office, including heart attacks and falls, right? Stuff that doesn't involve your treatment, but just bad things that are going to happen or could possibly happen. And then this is a super duper important one. How will first responders get from the street to your office? How will they get through a locked vestibule if you are delivering CPR? If you have a buzzer system in your building where they have to call your cell phone and then you have to answer the phone and press a button in order for the door to open, you need to keep that in mind when you call 911, right? You have to tell the person, you have to tell the phone operator, the 911 operator, hey, I have a buzzer system where I'm going to need to get off the phone with you in order to let EMS in. Make sure, if that's the case, make sure you always have your phone charger with you in your office, right? If your phone dies, you might not be able to let EMS in. So those are all really important considerations. If you do have an emergency situation, hopefully nobody does, knock on wood, what I want you to do is handle it, and then in the spirit of minimizing accidents, evaluate what happened and what you could do to prevent its reoccurrence. Take the next step, which is to share your learning with others. The best lessons are learned vicariously, but nothing is more effective than learning a lesson the hard way. All right, some other things to keep in mind. Summoning help from the outside. If you dial 911 or the equivalent, remember, to speak slowly and clearly when you explain what's happening. The dispatcher will likely ask you things like, what happened? What's the emergency? Where are you? Who needs help? Who is with you? Are you safe where you are? Generally, they will want you to stay on the phone until they tell you to hang up, which will usually be when EMS arrives. If possible, have someone greet the responders and guide them to your location while you stay on the phone, while you stay with the patient. All right, a couple more things here. We are almost to the end. Miscellaneous. I don't want this to paralyze you with fear. The truth is that mostly bad things don't happen for us. Every once in a while, bad things happen, right? Accidents happen, scary things happen, but that is true for all walks of life, all facets of life, right? So don't let these things strike fear into your hearts, but let it inspire you to arm yourself with knowledge. That's really what I want you to do. Please be conscientious and alert, but not paralyzed. All right, next section, this Our Litigious Society kind of talks about getting sued, talks a little bit about ethics, so I want you to read that on your own. It's kind of more of a section to ponder. But last little chunk here, your personal health and safety. So we've talked a lot about emergency scenarios, right? But here are a few other example scenarios that you should think about after you start working, whether that's in a classroom, in a treatment room at school, or your own treatment room out in the real world. So what happens if you fall in the bathroom and could not get up, or you knocked yourself out and you had a patient on the table with needles in? What would that look like? What would happen? If you get locked in the elevator on a Sunday afternoon, what would that look like? What could you do? If you get locked out of your office with only your lab coat in the middle of Chicago winter. If the power goes out and the emergency lighting is inadequate to illuminate your path. What if a patient threatens violence and you are alone? Either at a house call or in your office. A new patient requests a house call. This patient was not referred to you by anyone you know. So they just say, hey, I found you off of Google. Or if you arrive early to your office to discover that someone has broken in overnight. These are all scenarios that we should think about how we would handle them. All right, so we'll talk more about this stuff next week. I will have some A's for your Q's. We'll do a Q&A. So if throughout the time you were watching this, any questions came up, be sure to write them down and come to me when we come back from our 4th of July little mini break here. So we will reconvene on Tuesday, July 11th, a week after the 4th of July. This is the lecture portion of these notes. I'm also going to be asking that you watch the CNT Cleanfield setup video as part of making up the time for the 4th of July. So please watch this. If you're here, you finished this video. So please make sure that you watch the other video as well. All right, I hope you all have a safe and happy and healthy 4th of July. I will see you on the 11th.